presenters will be providing an overview of evidence-based nutritional guidelines and practical dietary recommendations tailored for patients using GLP-1 receptor agonists, focusing on optimizing weight loss, managing side effects, and supporting long-term metabolic health. Feel free to put any questions, comments in the chat or the Q&A related to today's topic, and we'll have time for Q&A as well as sharing resources at the very end. And don't forget to mute to minimize any background noise. I'd like to acknowledge our Eatwell co-leads, Professor Carrie Kreutzer with the USC Leonard Davis School of Gerontology and Keck School of Medicine, and Lindsay Pine, our dining dietitian with hospitality. And also thank the members of our Eatwell subcommittee who have been working hard to create a health-promoting food environment at USC. And as always, a reminder to feel free to stand, stretch, move during today's session. And with that, it is my pleasure to introduce our presenters for today. We have Dr. Harry Wong, physician and assistant professor of clinical surgery with the Keck School of Medicine in the Department of Surgery, and Diana Hong, outpatient bariatric surgery dietitian with the Division of Upper GI and General Surgery and Bariatrics. And I will turn it over to them.
All right. Thank you everyone for joining us during your lunchtime. If we can advance to the next slide. Like Julie had mentioned, I'm one of the bariatric surgeons here at UIC. I also run a multidisciplinary weight management clinic where I utilize medications, surgery, and also additional endoscopic therapies to help patients achieve their weight goals. So we're gonna get started. I'm gonna first by starting, with the definition of adult obesity. There's really no consensus on the best way to define obesity. And you can see I've listed a couple definitions from different professional societies here. The CDC defines it as weight that is higher than what is considered as healthy weight for a given height. So it's kind of referring to BMI or body mass index. Now, WHO says it's an abnormal excessive fat accumulation that presents a risk to health. And my favorite one, which is from the AMA and ASMBS, which is our Bariatric Surgery Society, that says obesity is a chronic, relapsing, multifactorial neurobehavioral disease characterized by an increase in body fat that promotes adipose tissue dysfunction and abnormal fat mass-related physical and psychosocial complications. So it's a lot of words there, but I think it packs a lot of, what actually it means to be obese or overweight. And typically, the definition, as you see here, is based on body mass index. It's not the perfect measurement, but that's kind of what insurance go by, what we go by in the medical world. And if you have a BMI of greater than 30, it's considered obese with three different categories of obesity. Next slide, please. And about 1 in 8 people in the world have obesity. And in fact, in the United States, almost 3/4 of our population are either overweight or obese. And obesity as a disease affects every single organ system, as you can see it on the picture in the right, right? It can give you high blood pressure, high cholesterol, metabolic syndrome, acid reflux, problem with your liver, diabetes, PCOS, lots of different things. And it is, more and more people are starting to recognize that obesity is not only an underpinning of major chronic disease, but a serious debilitating condition in its own right. I think there's a lot of stigma out there about, oh, you're can't lose weight because you don't have willpower, you're just weak. And it's not. It's not due to a lack of willpower. It's such a multifactorial disease that has many different components that I'll kind of discuss in a little bit. Next slide, please. So this is a picture I actually showed to all of the patients that come through my weight management clinic. I call it the tug of war of weight management. You can see on the weight loss side, all we have are reduced calories and increased activity. But on the weight gain side, there's so many more other factors that's pulling you in the other direction. There's this set point theory that's been pretty well established that basically says anytime you lose weight, your metabolism will slow down, your hunger hormone will go up, and your fullness hormone will go down. It's basically your body trying to get you back to the higher weight anytime you lose it. So once you've gained the weight, it's really difficult to lose it. Next slide. Is it advancing? Okay, there we go. And here's not even a complete list, but a list of a lot of the contributors to people gaining weight and the ability to lose weight. And you can see in this long list here, most of these factors are not under your control, right? You have genetics, environmental, lack of sleep, pregnancy, aging is a big one, and specifically in women, menopause, you know, your fat cells in your body are actually some of the most hormonally active cells. They secrete a bunch of, inflammatory cytokines in addition to, the hunger hormones. So there's actually very little you have control over, which is why, we need more people on our side to actually help. Next. In the year 2026 now, we have a lot of tools in our toolbox to help people lose weight. On the foundation, which is all the way on the left here, we have lifestyle changes, which includes nutrition, behavior, and exercise. That's basically the foundation of all weight management. As you move to the right, we have really good medications now, which we'll talk about. And all the way on the right is bariatric surgery, which is the most effective way we have to help people lose weight. And there's sort of a newer field of endobariatrics, which is endoscopic therapies for weight management. Next slide. And this is a list of current FDA approved medications or pharmacotherapy for weight management. Actually, I'm missing one here. There's a new medication that was just approved last month, December of 2025, which is an oral version of the semaglutide, which is a GLP-1. And we'll discuss that further. Next slide. So what are GLP receptor agonists? So GLP-1, also called a glucagon-like peptide 1, is a hormone that's naturally produced by your body. We call them incretin hormones. They're naturally made in your intestines, but it's broken down pretty quickly in response to food. Now, the synthetic version of the hormone, which is in these medications, it's basically, and you have receptors for this hormone all over your body. And then the synthetic version of the hormone is basically activating those receptors constantly. And you have receptor for these everywhere and it kind of works in multiple parts of your body. But the main mechanism of action I like to summarize into kind of three different things. Number one, it works in your brain by reducing the appetite and increase your satiety through your central nervous system. It also slows down your gastric emptying, so food stays in your stomach longer, so you feel fuller longer, so you eat less. And additionally, it stimulates the pancreas to produce more insulin, which is why it helps patients with diabetes. And see a little lizard picture up on the right-hand corner there. So that's a Gila monster lizard. So that the GLP-1, the synthetic version, was initially isolated from the venom of this lizard. That's when it was first discovered. And how this lizard killed its prey is actually by inducing pancreatitis. Next slide. So currently there's two different GLP-1s on the market. One is semaglutide and the other one is tirzepatide. Now there's different brand names for it. So semaglutide comes in the brand name of Ozempic, Wegovy, or Rybelsus. The injectable version, Ozempic, is just for patients with diabetes, while Wegovy is just for weight loss. Versus tirzepatide, which comes in the version of Mounjaro and Zepbound. Again, different brand name, but same medication. Mounjaro is for patients with diabetes and Zepbound is for weight loss. And additionally, the tirzepatide actually has another receptor target, which is the GIP receptor, which is a glucose-dependent insulinotropic polypeptide, which helps kind of boost up the additional insulin sensitivity component and also help counteract some of the side effects. Next slide. So what are the indications? So these medications are indicated for a patient with type 2 diabetes because we know it stimulates the pancreas to produce more insulin. So you get more glycemic control. And that, again, comes in the version of Ozempic or Mounjaro. And it's also approved for obesity and weight management, specifically for adults with BMI greater than 30 or for overweight, which is BMI greater than 27, with at least one weight-related comorbidity. Specifically for Wegovy, there's, risk reduction in cardiovascular disease, liver disease, and kidney disease. And for Zepbound, it's specifically approved for obstructive sleep apnea. But the main thing we need to note here is both medications require adjunctive lifestyle intervention, including reduced calorie diet and also increased physical activity for their obesity indications. And all the results from those randomized trials about how well these medications work is done in combination with these lifestyle changes. So you can't just rely on just taking the shot and, achieve your goal. Next slide. There are some contraindications and cautions. There's an absolute contraindication, which is a personal or family history of medullary thyroid cancer or multiple endocrine neoplasia type 2, MEN2. Although the increased incidence of medullary thyroid cancer was only observed in rat studies. It was never actually seen in human, but regardless, it's a black box warning, so it's one of the major contraindications. It is also contraindicated in someone who's pregnant or breastfeeding, mostly due to we don't really have data for it. And in fact, there's no weight management medication that is approved to be used during pregnancy. And then safety considerations, because of how this medication works, you can see why it would be, we use it incautiously when patients have gastroparesis, history of pancreatitis, gallbladder problems, or pre-existing diabetic retinopathy, GI diseases, or severe renal impairments. There are some common side effects, which are mostly GI related. I would say probably 50 to 70% of patients will experience some version of these side effects. The majority of these side effects are happening when you're first starting the medication or when you're going up on the dose. So if you can kind of manage some of the milder symptoms, you can, they usually get better. And serious side effects include pancreatitis, gallbladder issues, hypoglycemia, or diabetic retinopathy. So there's a couple warning signs you want to watch out for if you're having severe abdominal pain or nausea, vomiting, not able to take in anything by mouth. That's the time to go to the emergency room. And I might have gone over a little bit. I'm going to turn it over to Diana to talk about the diet recommendations.
Thank you so much, Dr. Wong, for that. That was so informative. And so, as you can kind of see, um, these medications do cause changes in digestion and appetite. So that's why nutrition and working with a registered dietitian is going to be key to kind of help manage those side effects as well as prevent any nutrition inadequacies. Next slide, please, Julie. As Dr. Long just mentioned, I kind of wanted to really re-highlight again some of the most common side effects when starting the medication or kind of going up on dosage. As you can see, a lot of these are related to our GI tract. So nausea, diarrhea on the other end of the spectrum, constipation, abdominal pain, fatigue, gassiness, bloating, hair loss can be seen when it comes to rapid weight loss, muscle and bone loss, and nutrition deficiencies. And so working with an RD to kind of help mitigate these symptoms, management of those things, and also just kind of keeping an eye out on patients while they are kind of going on their journey with these medications. Next slide, please, Julie. When it comes to supporting patients while they're kind of going through this, my job is to kind of help first complete a baseline nutrition assessment and screening, kind of see what's going on with them, seeing if they're having any side effects, kind of just warning them about them, and to kind of keep us updated if they're experiencing them, getting to know them and their dietary preferences and intakes and how we can kind of help manage their diet that way, preventing any nutritional deficiencies, whether it's kind of through food or supplementation, preserving as much lean muscle mass as possible and preventing any bone loss. Of course, maximizing that weight loss that we're looking for, and then the promotion of other supportive lifestyle measurements. So exercise, sleep, stress management, hydration, those sorts of things. Next slide, please, Julie. So all nutrition groups are super important and key, but I would say these are the top three that we kind of focus on. So of course, the first one being protein. As we know, protein can help preserve muscle mass during weight loss. It also helps keep you nice and full for a lot longer, and it kind of helps support our metabolic weight. So muscle loss is often accompanied with these medications, not due to the drugs themselves, but really from that reduced caloric intake caused by the appetite suppression. So we talk a lot about animal-based protein sources, non-animal-based protein sources, and of course, protein supplementation through things like protein shakes, protein bars, if they really feel like they have a low appetite. I also really like to focus on fiber intake. We know that fiber can help improve our glycemic control, help keep our blood sugars nice and stable, helps support digestion and fullness, really helps with those GI side effects, especially with constipation. Increased fiber can really help that. And then focusing on hydration, wanting to prevent dehydration as much as possible. So working on practicing sipping fluids throughout the day, trying to get at least minimally 48 to 64 ounces of water in a day. But overall, really recommending a nutrient-dense diet and of course, supplementing when clinically indicated. Next slide, please, Julie. On top of focusing on our food groups, really working on meal timing and structure. And so really working with patients on doing three smaller protein-rich meals throughout the day and then trying to squeeze in those 1 to 2 high protein, high fiber snacks in between. Working on having a consistent eating schedule. One of the challenges with these medications with the suppressed appetite is patients tend to want to skip meals because they're not hungry. And so really avoiding that to make sure that they're meeting their nutrition goals. Next slide, please. Beyond just focusing on weight loss, really working with patients on kind of long-term health goals. So sustainable eating patterns, focusing on behavioral changes, whether it's getting them to start meal prepping more, working on stress eating, eating when they're bored, those sorts of things, encouraging resistance and strength training to kind of help preserve that muscle mass as much as possible, avoiding overly restrictive diets. So thinking about what can we add to our diet versus take away to make a more balanced plate, those sorts of things, because eventually in the long run, they may or may not be on these medications anymore. So making sure they are nice and supported even when they're not on these meds in the future. Next slide. In summary, we know that obesity and overweight is a disease that has very significant health impacts. And so having these GLP-1 medications can help change digestion and appetite, which can help aid in weight loss. We know that nutrition is essential for safety and effectiveness of these medications. The medications can help one thing, but we also need diet and exercise on the other end as well. Really prioritizing protein, hydration, fiber, meal structure, is really going to be key. And of course, following with your whole team of providers, so Dr. Wong, myself, to kind of help improve outcomes.
Great. Thank you so much, Dr. Wong and Diana, for that overview and really great information. We do have questions that are coming in, so let me just shoot them off to you to answer. The first one is, can GLP-1s cause stomach paralysis, and how common is that?
Right. So GLP-1, one of the way I kind of mentioned it briefly, one of the way it works actually is slows down the entire GI tract. It's not just the stomach, but it does cause what we call delayed gastric emptying. And it's relatively contraindicated in someone with gastroparesis, which is, issues with the stomach emptying. Now, for like any of the other side effects, I would say for the most part, the effect on the gastric emptying tend to be temporary. And if you look at the numbers, probably about 1/3 will still have some persistent delayed gastric emptying after having been on the medication for a long time. Although I would say over half, things do tend to get better as your body get used to the medication. And as long as you're on the medication, it does still slow down your gastric emptying a bit. Although there's been studies that actually looked at specifically how much it slows it down. And there's one study, sometimes when we measure gastric emptying, we look at, the amount of time it takes for the stomach to empty half of its content. And then the study found is actually the increase in time is only 30 minutes extra. So not ridiculous. And for the most part, once you stop the medication, the stomach function tend to come back. Although there is some reports of, some patients who have persistent issues with, gastroparesis or stomach paralysis, in the long term, but that's pretty rare, but can happen.
And how do GLP-1s affect those that may not be obese and using it for aesthetic reasons?
That's a very interesting question. I think, there's already a lot of, there are definitely people out there that, don't quite meet the criteria for the BMI reduction, that are on these medications. My real answer is we don't really know, right? Because the randomized controlled trials, all the studies have been done using patients that are overweight or obese. So we don't really have good evidence or level one evidence to kind of tell us about the safety or the effectiveness for patients that are normal weight. That being said, right, we know that overweight goes beyond just your BMI, right? Just because your BMI is normal, right? There's other definition of obesity. Some people might carry their weight more in their midsection, or they might have higher body fat percentage. Some people may have more muscle mass. So it's kind of a difficult question. And in fact, between different race and ethnicities, there's actually different technically BMI cutoffs, for example, in Asian patients, we usually have a lower threshold in terms of a BMI cutoff in offering weight management options. So I think at the end of the day, right, like it comes down to risks and benefits. And I think if you're normal weight who just want to lose a few extra pounds, these medications do have risks, right? There are some serious risks. They're rare, but if they were to happen, it can be pretty serious problem. So that's why, we think obesity carries so many comorbidities. That's why, we think the benefits of these medications outweigh the risk. Now, if you're just doing it, you don't have any medical problems, you're healthy, you just want to lose a couple more pounds, and are you willing to take on that additional risk of potential complications? And I think that is kind of yet to be determined.
Great. The questions are coming in. Here's one about if you stop the medication, will you gain back all the weight, or are GLP-1s a lifelong thing?
That's a wonderful question. I'm so glad someone asked that. So as it stands, all the societies and consensus is that, these medications are meant for long-term use. Okay. There's in one of the clinical trials, they did show that once you stop the GLP-1 medication, majority of the patients gain almost all of their weight back. However, how they did it in the study was they basically revved up everyone's GLP-1 dose to the highest dose possible, and they had them quit cold turkey. And then all the patients gained their weight back. So now in my practice and a lot of other obesity specialist practice, we are kind of working with the idea of like once you've achieved your goal weight, like we can play around with like can we start to like either reduce the dose or finding a maintenance dose, or maybe like spacing out the dose instead of a once weekly injection, we could do it every 2 weeks, every 3 weeks, and trying to kind of slowly taper you off. And, some people have had some good success. So the jury is still kind of out, but that's kind of my long-winded answer. Maybe.
Right. And this person's asking a different person saying, do you recommend patients use small dosages to maintain and once they hit their weight goal to get off completely?
Well, I guess technically, right, like these medications are not approved to be used in that sort of microdose kind of fashion, although it is an option, right? And I think we need more research, more data, more studies to kind of show us how how well it's going to work. In fact, I do sometimes will utilize a microdosing strategy for my patients who can't tolerate the standard dosing of sort of like, the doses that's been studied in the clinical trials. I will have patients come in that, have serious side effects, say, oh, I just can't tolerate the medication. Sometimes I actually tell them that may be a good thing. That just means you might be a super responder. So one of the strategies is actually start from a subtherapeutic dose and slowly get them up. But I think there's no like good evidence for that right now. And I think there's more and more studies being done. I think it's a very exciting area. We kind of am excited to see what pans out.
Are there natural ways to increase your GLP-1 instead of doing the injections?
Yes. A lot. I'll have Diana talk about kind of the diet portion. I think there are some, specific food items that can increase your body's natural GLP-1. One of the things that can increase your natural GLP-1 level is exercise. However, the caveat being our endogenous GLP-1, so the GLP-1 that our body releases, the half-life is like a couple hours. Your body breaks it down pretty quickly. And the difference with this medication GLP-1 is it's a different molecule, right? Our body cannot break it down, so it just hangs out for much longer. So it's like stimulating those receptor constantly.
Some ways
And
that
this,
you can, oh, I'm sorry, Julie.
go ahead, Diana.
Oh, I was going to say on at least the diet portion of being able to kind of increase it naturally, fiber is going to be really important. So high fiber foods, so think of things like your fruits, your vegetables, whole grains, can help stimulate GLP-1s in your intestines. Greek yogurt with the probiotics, prebiotics can kind of help. Protein, of course, is going to be really beneficial. And that's keeping it pretty brief, but kind of some of the key takeaways of that.
And Diana, this one's for you. Is it mandatory when starting these medications to have a consult with a registered dietitian? And is there follow-up after a few months with a registered dietitian? How do you fit into this?
Yeah, so at least here in Dr. Wong's clinic, he sees the patients first for their initial visits, and then they get consulted to me. So I see them for an initial telemed, and then we kind of set up follow-ups on a month-to-month basis. It's, I believe it's not mandatory in other programs. It's just highly recommended, and it's something that Dr. Wong and I really like to do here at least.
Great. And then for treatment of sleep apnea, does there also need to be a diagnosis of obesity or overweight?
Typically, yes. Although, but right, you think about it, because sleep apnea, obstructive sleep apnea comes in a couple different forms, right? If losing weight is not going to actually reduce the amount of kind of tissue in the area, then it's, if you're already normal weight, it may not be as helpful. In fact, that's kind of led to some policy changes. Most recently, starting January this year, Medi-Cal has removed weight loss medications, GLP-1 for weight loss as a coverage, with the exception that you can still get tirzepatide if you have sleep apnea, but but your BMI has to be above 40 to get it on Medi-Cal at least.
And how long has these been approved for diabetes, and what are the long-term effects looking like?
Yeah. So it's actually because it's been, I would say, at least 20 years since, because these GLP-1, the tirzepatide and semaglutide are more recent, but it's more for weight loss. Actually, GLP-1 as a class of medication has been around for like much, much longer, and we know long-term safety it's definitely there. It's very safe. So that's why, we feel pretty good about using these medication for patients.
What about GLP-1 supplements? Are they effective? Are there supplements?
There are supplements out there that kind of tout the ability to like boost your natural levels of GLP-1, but I don't think there's any good evidence to support, at least from the supplement world. Now, that being said, I mentioned the oral version of the Wegovy pill. So the pill is released now. It's like literally came out to market 2 days ago. So it's the GLP-1 pill for diabetes, Rybelsus, has been around for a long time. But I think people weren't losing as much weight on it. It was great for people to control their diabetes, but people weren't losing weight. And but the Rybelsus were given at 5 milligrams. So this new semaglutide dose is 25 milligrams. So it's a much higher dose, and we're seeing almost like as much like 15 up to average 15% of total body weight loss with the oral pill. That's a GLP-1, but it's a little bit more like kind of you have to take it every day and you have to take it in a very specific way. And the problem in general with people trying to say, oh, just take this oral GLP-1, right? GLP-1 is a peptide. So by definition, it's a protein. What does your body do to protein? It digests it. So that's the problem with, having it taken by mouth is like it just like doesn't hang out for as long.
Great. And we're running out of time, so we're going to wrap up. I see Dr. Kreutzer's typing some answers into the Q&A. So we'll take a look at that and we can send out any answers that we haven't covered here. But I wanted to say thank you, Dr. Wong and Diana, for this informative session. I'm sure we'll be getting a lot more questions and really appreciate your time and expertise being here today. So we'll take the next couple minute or so to wrap up and share. Lindsay, are you here? Would you like to share the next couple of
Yeah,
slides?
sure. Hi, everyone. I just want to jump in here real quick and remind you all of the great resources we have on the Eatwell website, including the Eatwell YouTube video recipe library with over 100 easy, balanced recipes. And there's also multiple healthy eating guides that span eating on campus to Trader Joe's and the USC Village. So you definitely want to check those out. Next slide, please. So we're going to start highlighting a different Eat Well meal each month that we serve on campus. And all of these Eat Well meals are curated to fit within a set of nutrition guidelines. And so today I want to highlight the guacamole bowl from Taco Taco. It's located at the Tudor Campus Center food court. It includes salad mix, brown rice, black beans, sauteed fajita veggies, roasted corn, guacamole, and a lime wedge. Diana talked about fiber, and this bowl is plant-based, and it is an excellent source of fiber. Pretty tasty too. So look for the Eat Well icon when ordering on the Campus Dining mobile app or the kiosks. Next slide. And then finally, just a reminder that the Eat Well Committee put together a cookbook that features recipes exclusively written by USC staff and faculty. It includes breakfast, lunch, dinner, snacks, sides, and desserts, and it is currently live on the Eat Well website and is a free resource that you can download. So I'll turn it back over to you, Julie.
Great. Well, thank you so much, Lindsay, for sharing all those great resources. Our next session, we're very excited to share coming up February 5th. Hope to see all of you there, is backed by popular demand. We're doing the Setting Up Your Home Kitchen for Success Part 2. Well, we'll have Greg Harlan from Keck School of Medicine and Chef Pablo to show different equipment, things you can purchase to set up your kitchen for more balanced, nutritious meals. And with that, we will end with our raffle and also ask all of you to fill out our short evaluation form, which will be posted in the chat. Your feedback is really important to us. We do look at your suggestions to help plan future Eatwell Bites. So thank you so much. And we will now do the raffle. I see it. Let me stop sharing my screen here. And I do see some more questions coming in that haven't been answered. We will capture those unless Dr. Wong or Diana wants to answer them now, but we will get them answered offline and send out an email. Myra, are you ready with the raffle? We're raffling off a $25 Amazon gift card to all of our participants who chose to be in the raffle today. And Suzanne will be in touch with you to coordinate delivery. Bernard Yao, congratulations. Thank you so much, everyone, for being here, and enjoy the rest of your day and eat well. Good to see you all. Dr. Wong and Diana, if you can stay on, that would be great. And Lindsay, Carrie, team.